Hello, my name is Dan Stark, as you can see, and I'm a medical oncologist from Leeds in the north of England, and it is just so marvellous to be here. We have been working together, as I will tell you, on European aspects of teenagers and young adults with cancer for many years, most recently with the support of the European Union through the ENCCA project. And I'm going to speak to you about why we may focus helpfully on teenagers and young adults with cancer, and why and where we can take this field in the future. This is not something that's my own work that I'm talking about. It's the work of a large group of people. This is the steering group for our growing and increasingly succeeding European network for teenagers and young adults with cancer, which came out of the ENCCA project. Of course, in particular, Alvaro and his colleagues, I should point out, is on this for today, and other speakers who you will hear from through the day. We need to improve outcomes for teenagers and young adults with cancer because, and mainly I believe because, otherwise they fall down the gap between established services. There are established services for children's cancer, and there have been since the 1970s probably in some countries and later in some others. There are very well-established treatment centres for adult cancer, but adolescents and young adults are not the focus of either of those services, and sometimes they are even the source of a competition between those services, which does not help the young people themselves to get high-quality care and support when they have their cancer. They have a very strange spectrum of types of cancer. We don't know as much as we should about how to treat cancer, many cancers in teenagers and young adults, because the entry into clinical trials is disappointingly low. In some areas, teenagers and young adults, in some cancers, teenagers and young adults have poorer chances of recovering from their cancer than either younger children or slightly older adults, which I think can emphasize the gap that these patients can fall down. And of course, there are many psychosocial issues and ethical challenges, which I won't particularly discuss in detail today, because others will later. We are familiar with the spectrum, of childhood cancers, with a lot of acute leukemia, a growing number of brain tumors, and some lymphomas growing in incidence into adolescence. What we see is that the cancers in 15 to 19-year-olds is a very different spectrum of diseases from that in 5 to 9-year-olds or younger children still. We see the beginning of the rise in carcinomas and an increasing number of sarcomas also. If we take that trend further forward into the period of 20 to 24 years, we see a dominant pattern of lymphomas, epithelial cancers, carcinomas, germ cell tumors, and a very reduced number of leukemias. It is easy to look at a slide like this and think that all of these represent one illness or one disease. And of course they do not. And I will come on to show you some of the growing data that these tumors occurring in patients of 15 to 19 and 20 to 24 are quite different from the diseases occurring in 10 to 14-year-olds, potentially, in terms of their biology. This is an under-researched area where we need more work to be done. This is some American data from Blair looking at the chances of surviving 5 years from cancer by age. This is the chance of survival. This is age at diagnosis. And in an American model, this is 18 to 39, the group of their AYA with cancer. Same graph here. What we can see is in Blair's American data from the late 1990s. The chances of cure of breast cancer, bowel cancer, soft tissue sarcoma, non-Hodgkin lymphoma, and leukemia was lower in teenagers and young adults than either their younger child comparator groups or slightly older adults. We can see that in thyroid and testis and melanoma, the results were somewhat better in teenagers and young adults than in the very rare illnesses of these sorts in younger children or in much older adults. We see different outcomes. The main message here is slightly that there are poorer outcomes, but it is mainly that there are different outcomes. And we need to understand these differences to understand how to improve these situations. This is unpublished United Kingdom data looking at a similar question from the early 2000s. I have 3 graphs. I have the work here. These are the cancers where children have a better odds of 5-year cancer-specific survival than teenagers and young adults, who still do better than slightly older adults. These are leukemias in this era in the UK, germ cell tumors, and lymphoma. This is where teenagers and young adults do a little better than the comparator group, and the only cancer with childhood AYA cases and slightly older, where this is the case, are central nervous system tumors. And these are the cancers where teenagers and young adults have a less good chance of survival than either comparator group, and these are non-Hodgkin lymphomas, bone tumors, soft tissue sarcomas. Common cancers in teenage and young adult age range, where your chances of a curative treatment are lower if you are diagnosed as a teenager or young adult. In the UK, in this era. We have to put this in some context. We have to provide some history behind this finding. This is a graph many of you will know, comparing a children's to an adult's approach to treating 15 to 20-year-olds with acute lymphoblastic leukemia. You can see from this very influential paper by Boissel over a decade ago the large difference if a child's approach was used for the patients in the AYA age range compared with the adult approach. This was, I think, somewhat unhelpfully followed by an editorial saying that this difference was because of the approach of children's doctors, and suggesting that the approach of children's doctors might be a better approach. Actually, I think the differences were about the drugs that were being used, not necessarily the approach that was being taken. This caused a big battle that made it much harder to collaborate between adult and children's services for many years, which was very sad. This is data in Ewing's sarcoma from Michael Paulison from a long time ago, showing that in these early studies, if you were any age and you were treated for your Ewing's sarcoma in a center with a pediatric expertise, you had better odds of survival than if you were treated in a center without pediatric expertise. And so at these times, there was a feeling that teenagers and young adults were being treated with the wrong approach unless children's approaches were being used. These 2 areas have moved forward. These 2 diseases have moved forward. This is work on adolescent acute lymphoblastic leukemia, showing a big improvement when a pediatric-inspired approach to acute leukemia is used in adolescents and young adults with that condition. This is some data from Rachel Huff, presented 2 years ago in America, showing that the previous adult regimen for ALL in adolescents had a 55% odds of cure, and the pediatric, teenage, and young adult joint protocol increased that by 20%. This is progress from collaboration, progress from open, constructive conversations. These treatments, taken from children's into adolescents and young adults, bring about new and complex toxicities which need to be learned about together. The same was shown in Ewing's as collaboration came forward, a joint protocol with adult and children's physicians working together. Not only did the survival of all patients improve, but the gap between children's and adults' approaches disappeared and the graphs came together. There are still problems. Even if you find a protocol which can be delivered in principle, you still find it harder to give treatment to adolescents effectively than to young adults. This shows the time when the different phases of acute leukemia treatment were administered to young adults, the solid lines, or adolescents, the dotted lines. You can see that adolescents were having their treatments later. They were good at the beginning, but by the end of the treatment, they were getting their treatment started later. So there is more than just changing the treatment, the drugs. There is finding a way to give these drugs on time with manageable toxicities to different ages of patients with different biology and different needs for support. And these are the reasons why we need to continue to focus on adolescents and young adults with cancer. Why are these differences there? Why might this be the case? I think a lot is to do with poor trial recruitment. If you're dealing with many adult cancers, these cancers are very common. There are many thousands per year. If only 1 in 10 or even 1 in 20 patients enters a clinical trial, that trial can answer an important question. It will have the statistical power to answer an important question. If you are a young child and you have a rare illness, a rare cancer, but you have a history and an infrastructure to put almost every child into a clinical trial, you can answer the questions and improve things. But if you have a teenage and young adult cancer, which is neither common nor does it yet have the structures to put all the patients into trials, you cannot answer any questions. It is very hard. We have disappointing improvements in outcome over time for teenagers and young adults, and many of us believe this is because of this problem. There are differences in biology, and I will tell you more of this. There are longer times to diagnosis in patients who are older than 12 than under 12. There are difficulties with adherence to treatment, as I've shown you in that Bossell slide. And there is some growing evidence that if you have specific communication, support, flexibility, and young people are treated with their peers, some of these problems with treatment adherence, taking the treatment as prescribed, will reduce. Another reason to have specialist services for teenagers and young adults with cancer. This is data from, with thanks to Lorna Fern from the NCRI group in the UK, showing the proportion of patients recruited to the Euro-Ewings and the Euro-99 and the Euromos-1 study across ages. These studies were open to 50 years or to 40 years. Even though they were open beyond into these age ranges, the proportion of patients recruited falls away very fast. This is enough patients if you are dealing with bowel cancer or lung cancer or prostate cancer to answer research questions. But it is not enough if you are dealing with Ewing's sarcoma and osteosarcoma. This may be some of the reasons why that is the case. Again, I'm showing you some unpublished new international data on teenagers and young adults with cancer. These are the phases of trials which are in the UDRACT register at the autumn of 2013 into the January of this year. These are the phases of trials for bone sarcoma. These are the trials which had age entry criteria appropriate to the sarcoma being treated. These are the trials that had age entry criteria going from early childhood through to early middle age. And these are the ones that did not have appropriate criteria, Perhaps the trial was only open for under 16s or only open for over 18s. And you can see that not all these trials have appropriate age entry criteria. This is the same data, but split by whether there was an academic or a pharmaceutical company sponsor for the trial. And we begin to see that we can improve these trials' design to make them more accessible to young people with cancer, improving our understanding and improving our results. The biology of teenage and young adult cancer is also different. The young person has a different body, different habits and medications, a different approach to illness, different hormones and growth of organs. So perhaps medication given to a 19-year-old will not be handled the same in the body as the same medication given to a 4-year-old or a 45-year-old. We do not know for certain, but this is maybe one explanation which we should study, why these findings, why our trial results are different in different age ranges. We know the late effects of cancer are linked to age at diagnosis. My colleague, Dr. Woodward, and I published this article on age-specific late effects for TYA some years ago. We know, and this is germ cell tumor data from Matthew Murray and his group, Palmer's group in Cambridge. These are germ cell tumors by age. These are seminomas and germinomas. These are non-seminomas. What we see is in this group, there is some cluster of young people here. These are principal components analysis of gene expression in these tumors. There is a cluster, but there are adults with an adolescent biology. This is the adult cluster, but there are adolescents with an adult biology. There are smaller numbers of these patients in the non-seminoma group as well. This is a quick list of other cancer areas and papers which show a similar effect, that the biology of teenagers and young adults with what might seem to be the same tumor is not necessarily the same. Moving to talk to time to diagnosis, this is complex. Thanks, Andrea, for this slide. We think it may take longer to be diagnosed with cancer if you are not clearly an adult who is confident to go to your doctor and describe your symptoms, and in whom your doctor is confident to communicate with you. We think it may take less time if you are a child and you go to the doctor with a competent adult, a parent or carer. We think it may take less time if you have grown accustomed to working with adult systems in each of our countries. But for an adolescent who doesn't understand this system maybe, and whose doctor does not know necessarily how they are working, it is difficult to get a diagnosis. But this is a complex area because there is not a clear line that says a longer diagnosis time means a worse survival, or a shorter diagnosis time a better survival. This is complex. It is mixed up with the type of tumor, the location of tumor, the size. It is a complex issue requiring further detailed study. To study this, you need to use the Aarhus process, derived by David Weller and colleagues and published, breaking the time from symptoms to treatment into a lot of different parts, examine these parts, and we are beginning to pilot some work on this in ENCCA. TYA needs special services. There will be more on this soon. We've known this a very long time, and there is a lot of research data. This is just a small part showing that this is the case. But the number of specialist services available around the world is relatively few. These are some photos from our unit in Leeds. We reviewed this issue with a student some years ago, if you're interested further. We know a little from Danny Kelly from Cardiff, his work on why this might be. He felt the mechanism of being in a specialist service was that all the young people were in the same boat. They were all sailing in the same direction together. They were protecting each other from the stigma of cancer, helping each other to communicate well with the doctors and nurses, and working with nurses who had a natural understanding from all of their work of how patients' needs were and to help them explore what they should do with their illness. Sam Smith, a teenage and young adult nurse working currently with the charity in the UK, is developing further her framework for nursing practice in teenagers and young adults. We've done some work on the ethics, which we're expecting to publish later this year, looking at the specific ethical and legal aspects of being a teenager or young adult. The law is not clear between different European countries. The ethical codes are not the same. There are big differences in consent, in fertility, in a whole range of issues. Another important reason, to draw you back to my title, to work and focus on teenagers and young adults with cancer. And so, our focus has been through ENCCA. ENCCA began in 2011 with three nations in Europe represented on the steering group. It has grown in 4 years, with all of these nations members joining the steering group. It is pushing forward a body of research and collaboration in teenage and young adult cancer with the membership of these and other countries, professionals joining as individuals our collaboration. It is developing our framework. It is educating professionals. It is working to understand and improve trial access. It is working on the research and registration. It is working on survivorship. And perhaps most important of all, as at today's meeting, it is putting the views of patients and their support organizations at the heart of what we do to continue to keep us on the ground, to stop us from feeling we know too much, and to tell us what we should be doing. We've got 24 member countries. We've got 18 countries active in current groups. We've produced professional standards that are jointly owned by a pediatric and adult collaboration. We're beginning to develop research and recommendations for services. We have young people at our centre. This is Mrs. Morgan's slide. This shows everybody on the same bus, all driving in the same direction, all working together to improve outcomes. We have advocacy embedded in what we do, and we've conducted an extensive patient survey in Europe. There'll be more analysis of this in the months coming. This is our second conference. This is young people on the platform discussing in Paris, chaired by the marvelous Professor Lewis, looking at what their issues are in having treatment. This is the faculty that put together that Paris meeting a year ago, and a link to your marvelous Spanish group, who are our kind hosts today. Our survey showed clinical trial entry for professionals, clinical trials, clinical trials, clinical trials. The key priority from the UK professionals, the north of Europe, the east, the south, and the west. But it also showed huge differences. How many countries had teenage and young adult units? How many countries had a definition of TYA? How many countries had funding for TYA services? We began with 3 nations. In the dark green, now we have involvement from all the nations in green here. If you're from another nation that isn't in green here and you would like to join us, simply find me over coffee. Give me your email. You can join. We have an examination of different models of teenage and young adult care in different countries. Some have a collaboration, some are building services from either adult or children's basis, and some have no national model yet. We have different ages as our focus. We have different numbers of units in place. We have different achievements and different next challenges. We can bring all this together in a future project to work on teenagers and young adults with cancer across Europe. We are working on the curriculum, how we train the doctors in the specific aspects for teenagers and young adults. This is the UK curriculum for medical oncology on the management of teenagers and young adults with cancer. We ask our young doctors training in adult or children's cancer medicine to know these things, to have these skills, to behave in these ways. And until they do so, they don't have a sign-off that they're ready to treat teenagers and young adults as competent senior doctors. We're meeting in London, 6th of July, an international summit to develop these curricula further. We're working on practice guidelines, which I won't go through in detail now. We believe the unit should not have age cutoffs that are restrictive, but serve their local community. They have to have the right environment, the right staff, and the right services, and they have to have clinical trials. We're working on the epidemiology, and anybody who comes to this conference as an epidemiologist, please consider letting me know you'd like to come to our workshop in June in Amsterdam, looking at how we develop the epidemiology for teenagers and young adults in the future. We're writing the next grant with 7 or perhaps 8 work packages looking at our strategy, epidemiology, how we involve patients and the public, how we improve trials, how we understand the outcomes, how we educate professionals, and how we ensure healthy survivorship care. Again, if you wish to join us, let me know. There is time and space for anybody who wishes to be affiliated to this next European project, if it's successfully funded. And so, to finish, you might have wondered if I would ever finish. To finish, TYA have unmet clinical and care needs in our current systems of a focus on children, a focus on adults. We now need a focus on teenagers and young adults. They need to improve their survival and the quality of that survival. So we need to understudy that, to understand it, to adapt what we do, and to improve. They need an environment of care that is neither that of small children nor that of older adults, but is specific to them. And they need professionals to collaborate, to work together, to provide the expertise and the leadership to make this service come into place. They are disadvantaged by our existing systems because of their focus and because of their boundaries. We are in a very exciting phase in teenage and young adult cancer. More and more countries are establishing these services, some having specialized wards, some with charities and patient groups at the heart. I cannot say too many times, collaboration is the key. In our next grant, these are our international bodies, which, if we are successfully funded, are collaborating to drive forward these services. Large organizations, PSYOP, ECHO, ESMO, the Nursing Society, the Research and Trials Group, the Medicines Agency, working together for a group of patients we can't serve alone. Thank you very much for listening. This is my email address. All of you with a stake in improving some part of teenage and young adult cancer can come together and learn from each other to improve outcomes in this area of care. Thank you very much. Would anybody like to ask anything at all, please. Not even you, Sue. Nothing. Okay. I will be present over coffee and right through the meeting, and I'm even spending the evening in Madrid on Friday, if you're not tired by then. I will be happy. I can talk about this for longer than you, I promise. All right, I will leave the next talk.